What are your thoughts about estrogen therapy for women, menopause, and hormone therapies generally for women, maybe even testosterone therapy? You hear about that these days. And then we'll talk about men.
So our practice is probably 70-30 male, female. So we have lots of women, and this is a very important topic. It's also probably, let me think. I just want to make sure I'm not being hyperbolic when I say this. Yep, I don't think I am. It's hands down the biggest screw up of the entire medical field in the last 25 years. Now, again, it's possible in the next hour I'll think of, nope, there's a bigger screw up. But
another giant screw up.
But I don't think I will. I'm pretty confident that I won't be able to think of a bigger act of incompetence than what happened with the Women's Health Initiative in the late 90s and early 2000s, which is effectively the study that turned the entire medical field off hormone replacement therapy for women. So it's important, I think, to explain what the study looked at. So this was a study that was conducted in response to the widely held belief in the 70s and 80s that women should be placed on hormones as they're going through menopause, right? Menopause is, I guess maybe I'll even take a step back. I don't know how much your audience is familiar with how estrogen, progesterone work. Is it worth going into that stuff?
Probably worth mentioning a bit of the top contour. Some of them might be familiar with it. We've done episodes on estrogen, testosterone, but frankly, as I think back to those, we didn't really go into the biology of estrogen, testosterone enough.
Yeah. So, I mean, actually an interesting aside that I always tell my female patients who get a kick out of this, when you look at a woman's labs, you'll see her estrogen, her progesterone, her FSH, her LH, her testosterone, her sex hormone binding globulin, all these things. But based on the units they're reported in, it's a very distorting picture of what the most common androgen is in her body. If you actually convert them to the same units, she has much more testosterone in her body than estrogen.
Interesting.
Yeah.
I did not know that.
Yeah.
Then again, I've never been a woman getting my hormone profile done.
Yeah. So even though a woman's testosterone is much less than a man's level, it's still more than she has estrogen in her body.
Wow.
So phenotypically, right, estrogen is the hormone that's dominating, and so it's she has much higher estrogen than a man and much lower testosterone than a man, but in absolute amounts, she has more testosterone than estrogen. Just worth pointing that out.
Incredible.
So, what's happening to a woman from the age she starts menstruating until she goes through menopause, outside of pregnancy and birth control and stuff like that, is she has this cycle, roughly every 28 days, but it can vary, where at the beginning of her period, we call that day 0, her estrogen and progesterone are very low. You can't measure them. And then what happens is the estrogen level starts to rise, and it rises in response to a hormone called follicle stimulating hormone, FSH, that is getting her ready to ovulate. And she ovulates at about the midpoint of her cycle. So if we're just going to make the math easy, on day 14, she's going to release a follicle from one of her ovaries. And the estrogen level is sort of rising. We love to measure hormones on day 5 because I want to have a standardized way in which I measure her hormones. So our women know, if we're in the business of trying to understand her hormones, the day her period starts, even if it's just a day of spotting, that becomes our benchmark. And then day 5, I want to see every hormone on that day. And if everything is going well, I know what her FSH, LH, estradiol, and progesterone should be on that day. So the estrogen rises, starts to come down a little bit as she ovulates, and then the luteinizing hormone kicks on because it's now going to prepare her uterus for the lining to accommodate a pregnancy. So now you start to see estradiol go back, but now for the first time, progesterone goes up. So progesterone has been doing nothing for 14 days, and now it starts to rise. And actually, progesterone is the hormone that's dominating the second half, which is called her luteal cycle. So the first 14 days is the follicular cycle, second is the luteal cycle. So once you get to about the halfway point of that, which is now, just to do the math, 21 days in, the body has figured out if she's pregnant or not. And again, most of the time she's not going to be pregnant. So the body says, oh, I don't need this lining that I've been preparing. I'm going to shed it. So now progesterone and estrogen start crashing, and the lining is what is being shed, and that is the menses. By the way, it's that last 7 days of that cycle that in a susceptible woman is what creates those PMS symptoms. So actually, this is something that you would probably have a better understanding of than me. There is something about this in a susceptible woman where the enormous reduction of progesterone so quickly is probably impacting something in her brain. So I think this is a legitimate thing, right? I mean, it's not like, oh, she's crazy because she's having all these PMS symptoms. No, we know that that's the case because if you put women on progesterone for those 7 days, those symptoms go away. So if you can stabilize their progesterone during the last half of their luteal phase, and sometimes we would just do it for the entire luteal phase, just put them on a low dose of progesterone, all PMS symptoms vanish.
Very interesting. I'll have to look up where the progesterone receptors are located in the brain. The Allen Brain Institute now has beautiful data of in situ hybridization, which for folks that don't understand is looking at RNA and sort of where genes and proteins ought to be expressed in the human brain by using actual human brain tissue sections as opposed to just mice. So I'll take a look. I think some insight into what that progesterone emotionality link might be and where it might exist neural circuit wise.
So then when the estrogen and progesterone reach their nadir again, that starts the cycle. So that cycle is happening over and over and over again. Okay, so it became, well known in the 50s that, okay, a woman's going to stop menstruating at some point. Her estrogen goes down. Why don't we just give her estrogen? Because that's clearly going to help with some of the symptoms of menopause. So what do women experience when they go through menopause? The first symptoms are what are called vasomotor symptoms. So this is usually in the form of night sweats, hot flashes. And depending on the woman, this can be really significant, right? These are women who can have a hard time sleeping. They can be having hot flashes during the middle of the day. They can wake up soaked in a pool of sweat. Those tend to pass after a couple of years, and then they get into sort of the more long-term complications of menopause. So what we call vaginal atrophy, vaginal dryness, and then the stuff that we talked about a while ago, which is the osteopenia, osteoporosis. A lot of women will complain of brain fog. Clearly this was an issue and it was recognized 70 years ago. Why don't we give women estrogen back to replace that hormone? And so that went on for a couple of decades, maybe less, maybe a decade. And then it was realized, wait a minute, we were driving up the risk of uterine cancer. And the reason for that is if you just give estrogen with no progesterone to antagonize it, you will thicken the endometrium endlessly, and you will increase the risk of hyperplasia. Well, you'll definitely undergo hyperplasia, and then ultimately dysplasia. Dysplasia is precancerous, and ultimately we were seeing that. So people figured out, well, actually, if you want to give estrogen to a woman who still has her uterus, you have to give her progesterone as well. You have to be able to have a hormone to oppose the estrogen. And then that became effectively in the 1970s-ish, the standard for HRT. So in the early 1990s, the NIH said, look, we haven't really studied this. We have a ton of epidemiology that says giving women hormones seems to be doing really good things. They feel better, so all their symptoms go away. They seem to have lower risk of heart disease, lower risk of cardiovascular disease, lower risk of bone fractures. Everything seems to get better, lower risk of diabetes. But we haven't tested this in a randomized prospective trial. So let's do this. So that became the WHI. And it had two parallel arms. So it had a group for women who did not have a uterus. So these are women that had undergone hysterectomy for some other reason. And then it had a group for women that did have their uterus. In the first group, there was a placebo arm and then an estrogen-only arm. And in the other group, there was a progesterone plus estrogen versus a placebo. Everything about the way this study was done is a bit wonky. Some of it is justifiable, but it's important to understand. First, the women were all way outside of menopause. So none of these women were started when you would normally start HRT. And there were probably several reasons for that, but one of them is, and I think this is a legitimate reason, they wanted hard outcomes. They wanted to know death rates. And if you're doing this on women in their 50s, you just weren't going to get it, right? You couldn't.
Wait too long.
Yeah, you got to wait too long. And this was only going to be like a 7 to 10 year study. So they had to do this on women who were much older. They also disproportionately took much sicker women. I believe the prevalence, and again, I'm going to get some of these numbers wrong and people are going to get all phosphorylated, but I'm in the ballpark, right? something like 30-40% of these women were smokers. The prevalence of obesity, diabetes was enormous. So they really disproportionately picked the most unhealthy population they could that was pretty advanced in age. And again, I think part of that was to say, look, we want to make sure that after 7 years, we really know if there's a difference in these causes of death. The other thing is, this is kind of weird. Although again, I understand their rationale for it, but this is a great example of be very careful when you look at a clinical trial that it remotely represents the patients you're interested in treating. So they also treated no patients who were symptomatic. The rationale being, if we include in the study patients who are symptomatic, those who are randomized to placebo will drop out.
Okay, it makes sense in terms of study design. Makes no sense if the study design is intended to mimic the real world.
That's right. So now let's just keep track of the three issues. We have a disproportionately unhealthy patient population who are not symptomatic, and we're starting them more than 10 years after menopause. The next thing that they did, which again, I understand why they did it, but it's now the fourth strike against this study, is, and I've spoken with the PI of the study and asked this question point blank. I'm actually going to have her on my podcast at some point soon to go over this in more detail. Is why did you use conjugated equine estrogen and MPA, which is a synthetic form of progesterone?
Horse?
Yes.
Estrogen?
So it's horse urine. Is they collect horse urine. So they're getting it's
horses do urinate a lot, or at least when they urinate, it seems like a large volume of urine from what I've observed.
You have a lot of experience with this?
No, but my sister rode horses for a little while. My high school girlfriend had a horse, and that thing, I mean, the peas were legendary. It's a male horse.
Yeah.
Yeah.
So the conjugated equine estrogen is the estrogen that's collected from female horses, and then it's a synthetic progesterone. And I said to the person, I said, well, why didn't you use what we use today, which is bioidentical estrogen and progesterone? Like today, when we put women on estrogen, we use it's an FDA product called the Vivel Dot. So it's a patch that you just put on, and it's estradiol, but it's bioidentical estradiol. And we use what's called micronized progesterone, so bioidentical progesterone. And she said, well, at the time, we just wanted to test what was currently being used. And I said, totally makes sense. But again, now you have four considerations that you have to keep in mind. Okay, so despite those four considerations, and I'm going to make a case for you why I think the MPA created a real problem in that study, the synthetic progesterone. When the preliminary results were first made available, but not yet peer-reviewed and not yet published, there was a huge fiasco, huge press announcement about it, suggesting that the women receiving the CEE plus MPA in the group with the uterus had a higher incidence of breast cancer. And that basically became the headline that never went away, though it turned out not to be true. Let's talk about the numbers. What was the increase in the risk of breast cancer in that group? Which gets to if you've ever listened to me on the podcast, rail on something.
Listen, I have about 3,800 pet peeves and counting. My laboratory staff know these, know a good number of them. So
here,
you do not have to apologize for having many pet peeves, because as long as they have experience and data to support them, it provides a better life.
So one of my biggest pet peeves is, and my team knows this because sometimes they'll occasionally, they'll do this and I'll have to remind them. You never talk about a relative risk change without an absolute risk accommodating it, right? So what does that look like? So the relative risk increase of breast cancer in the estrogen plus MPA group versus the placebo was 27%. And that became the only headline. HRT increases risk of breast cancer by 27%. Now, I don't think that's true at all today. But let's even look at the data. What was the ARR? What was the absolute risk increase? It was a difference between 5 cases per 1,000 and 4 cases per 1,000. So the ARR was 0.1%, 1 case in 1,000. And it's true, going from 4 in 1,000 to 5 in 1,000 is a 25% increase. But it's a completely inappropriate context.
I agree. And I feel like headlines of that sort which have come up recently around various dietary interventions, we won't go there, at least not for the time being, are nothing short of criminal, because they really distort people's thinking, but also they steer the course of science and medicine for, as you pointed out, for decades, if not longer. And they can really take us off our health track in serious ways.
So I'll bring this meandering to a close, which is to say, even though I could spend the next hour talking about all of the ways in which this study was flawed and all of the very unethical things that were done by a number of the investigators who went out of their way to mask the truth of this study from the world, I'll tell a woman today, we're going to start you on this when you're going through menopause. We're using bioidentical hormones. And if your upper bound risk of breast cancer is one case in 1,000, you should at least weigh that against all of the other benefits, which I'll talk about. Now, there's something else I want to say, because a moment ago I alluded to the fact that I think the MPA might have been the biggest issue in that study. So there were two findings in that study that were negative. One was the small increase in the risk of heart disease and the small increase in the risk of breast cancer. But consider the other group. We forgot about the group that didn't have a uterus. Because remember, those women got estrogen only versus placebo. What was the difference in breast cancer there? Well, this is interesting because it didn't reach statistical significance, but its p-value was 0.06 or 0.07. So it came very close, but it was in the opposite direction. It was a 24% risk reduction, about 1 in 1,000 as well. So when you had estrogen plus MPA, you had a barely statistically significant, the p-value was 0.05, so it just hit statistical significance, 1 in 1,000 cases for breast cancer. And then you had 1 in 1,000 cases, but p-value of 0.07 for reduction of risk of breast cancer, which to me suggests that the MPA, the synthetic progesterone, was playing more of a role than anything else. The second thing I point out is oral estrogen, which we no longer use, does increase coagulability. It does increase the ability of the blood to clot a little bit. And when we look at the more recent data on HRT using topical estrogen or patches of estrogen, we don't see that at all. In fact, we see the opposite now. So now we see the risk of heart disease going down in women with estradiol.
And some women will be arriving to those treatments with mutations in things like factor V Leiden and other clotting factors. Is it appropriate to say that everyone, both male and female, should know whether or not they have mutant forms of factor V Leiden?
You know, we don't typically test people for factor V. My wife actually has it, but we didn't learn it until she had HELP syndrome, giving birth to our first daughter. You know, we kind of look for more family history reason to be testing things like that. We take a pretty detailed family history, so we'll kind of look for clotting issues there.
What about, so your reflex nowadays is to put women on these topical estrogen therapies. It's
to basically have the discussion, right?
Yeah.
So here's where we still struggle, right? Is, you know, if it were up to me, I'd prefer for a woman's HRT to be provided by her GYN, because we want to be able to work in partnership with the GYN, who we would like to see an endometrial ultrasound done every year. That's, you know, some would argue that's overkill, but, you know, we think she should be having a pap smear every year as well. So if we're looking at the cervix, we want to look at the endometrium. We want to make sure the lining isn't too thick. The other thing I should say, Andrew, is today we now realize that not all women can tolerate progesterone. So you have to be careful. So assuming, again, a woman still has her uterus, the estrogen solves most of the problems, but then you have to decide, can she tolerate the progesterone? And it needs to be, if given systemically, like 100 to 200 milligrams. And for some women, that is a life-saving intervention. I mean, they start sleeping better, their hair gets thicker, they feel better. But for some women, it literally drives them crazy. It's probably the reciprocal of what we were seeing in the case of women with PMS. So in those situations, we say, great, we're done with oral progesterone. We just use a progesterone-coated IUD. So then you get the local progesterone in the uterus for protection and the systemic estrogen.
Fascinating. What about oral contraception for in women? So the use of estrogen chronically through people's, you know, college years or the 20s, 30s, maybe even teens, who knows? What's known about the long-term effects, if any?
I got to be honest with you, I don't think I know enough to comment on it. It's not something that really impacts my patient population. at least in what I see, more women are using IUDs for contraception than OCs. I mean, we use OCs sometimes in women who are premenopausal for symptomatic control, but we'll typically use like a low estrin, so a very low synthetic estrogen, which I don't like using these very much, but if it's the only thing that we can get to control certain symptoms, and we'll use it like half her cycle. But it's typically not something we're that experienced with.
What about testosterone? Because you mentioned that, nanogram per mil, when you set everything to the same, I guess it's nanogram per deciliter, as it would be to kind of normalize
versus
everything.
Picogram per mole. Yeah.
Right. Yeah. And so, what Peter was pointing out before is that you look at your charts and they're all in these different measures. And so when you normalize testosterone is actually higher than estrogen in women. That's a surprise to me. Do you prescribe testosterone therapy to women ever?
We do sometimes, but I do it with much more caution because I don't have the data, right? So where what we'll say is, look, I mean, we're now really outside of an area where I can point to a lot of data. Like when it comes to estrogen and progesterone, I'll happily go toe to toe with anybody who wants to make the case that it's dangerous. Similarly, when it comes to using testosterone in men, I'll spend all day and I can go through that literature until the other person cries and wants to just call uncle, right? When it comes
and then
to
you prescribe them testosterone.
When it comes to estrogen and testosterone in women, don't have that data. And I'd love to see that trial done. So what's the sweet spot? How do we reconcile that? So it's not something I consider standard. And basically, if her testosterone, first of all, is staggeringly low, and again, even though her testosterone is low compared to a male, we still have a range. So if it's really at the bottom of that range, she's really having difficulty putting on muscle mass and really complaining of low libido, I think in that situation, we'll go ahead and use topical testosterone. And replace her to a level that is still physiologically normal.
Yeah, that's key, because when people hear HRT, they think about super physiological. Seems to be the term.
Yeah, I've never seen a single symptom in a single woman that I've put testosterone on in terms of like acne, body hair, things like that. Like those are real symptoms that you have to be aware of. But like clitoral enlargement and things like that, like that doesn't happen under physiologic normal conditions.